too much pressure.
Oh no.
It's all right.
Performance anxiety. Losers get performance anxiety. Hi.
Hi.
Yeah, okay. Here's what's nice is that we actually get to look pretty much directly at each other.
Yeah, that is
instead of doing the whole head turn thing. So, hi, welcome to another episode of the Nuanced Naturopaths.
Yes, welcome.
I'm Karinda.
I'm Julie.
We're glad that you're here.
Very, very pleased.
And welcome to our new setup. Let's see what future Karinda makes of this in post-production.
I've said it before and I'll say it again. I have a lot of faith in future Karinda.
And she thanks you so much for having that faith in her. We're going to add on to our side effects episode, specifically around the conversation we were having about paracetamol, Panadol, acetaminophen, because a post by a highly regarded naturopath and herbalist in our field, who we love so much, Kerry Bone, a post of his caught Julie's attention where he was specifically talking about paracetamol and side effects of paracetamol and beliefs held around it. And we thought, oh my God, we did that episode so recently that we have to include this as part of the conversation.
Yeah, absolutely. Yeah, it's really vital. Particularly, as we said, we didn't mention it in the last episode, that one of the main reasons that people use paracetamol is as an alternative to the ibuprofens or the non-steroidal anti-inflammatories, which can cause gastric side effects.
Yes.
And given that, it is very important and valid information to add.
Yes. Oh my God, you just got a notification. A new episode of Severance is now on Apple TV.
Oh my God. I can't wait.
Oh shit, we've got to leave that in. Yeah, so Kerry Bone is specifically addressing the impact of paracetamol use on a few different things actually, but some gastric related things. And it's like, well, let's talk about that because people specifically avoid ibuprofen because would you say it's more known that ibuprofen, like it's more in the mainstream knowledge that ibuprofen can cause ulcers or just stomach discomfort? What's your experience or like what's your awareness of that?
For mainstream understanding, I think generally people know that it can cause gastric problems.
Yeah. So Panadol's the one that you go for if you're prone to gastric problems or if you've had issues with ibuprofen in the past.
Which can add to that perception that Panadol is safer.
Yes, exactly.
You know, it's just another layer that we don't want to take non-steroidal anti-inflammatories because they have this particular adverse reaction.
Yeah.
And so we'll have the safer one, Panadol. Or paracetamol.
Paracetamol, we should avoid brand names, /
acetaminophen.
Yes. So, should we just riff off what Kerry says?
Yeah, I should just say it's Professor Kerry Bone.
Professor Kerry Bone. Well, I mean, his Facebook page just says Kerry Bone at the moment. But he's a professor and he's a very talented and knowledgeable man.
That's right, and modest.
And we love him and he's very modest. Okay. Widespread belief holds that the popular over-the-counter painkiller paracetamol, acetaminophen, does not cause stomach ulcers, but a new study from the United Kingdom puts that in doubt. General practice records from 1998 to 2018 in the UK show that among 180,000 people aged 65 and older who received prescriptions for paracetamol, the risks of peptic ulcers, bleeding from ulcers, and any type of lower gastrointestinal bleeding were increased by 20 to 36% compared to more than 400,000 people not prescribed the drug.
But it is worth mentioning that it is not only, it is prescribed in the UK, but it's also available over the counter.
Interesting. Okay, that was not in my awareness at all. Oh, okay, interesting. And then he also says paracetamol use was also associated with increased rates of other health problems, including heart failure, chronic kidney disease, and hypertension. So what he's really speaking to here is this perceived safety versus, hang on, we have this data now. What are we going to do about it?
Yeah. Not as safe
No.
as advertised or perceived to be. And in fact, when you look at that list of conditions, heart failure, chronic kidney disease and hypertension, that's a significant portion of disease states that are already in really high numbers across all Western countries.
Without the help of paracetamol adding to the...
Yeah.
And the other thing I notice is that, let's acknowledge that the study was done in people aged 65 and older.
Yeah.
And, those people may be already maybe predisposed to some gastric complications just as a result of aging and, I mean, their health to begin with comes into question. But what's sad to me is that those associated risks with paracetamol use are going to be problems that affect an aging population more commonly than other people. And it's like, gosh, they're already at risk of these things because of their age and, so many other factors. And look, I could be wrong here, but I feel like it's also the older population that relies on analgesic medications to manage those niggly complaints like joint pain or, headaches, it's just it speaks to the accumulation of medications with age too. So the older you are, the more likely you are to be on more and more, an increasing number of medications. Yeah. And those medications might contraindicate something like ibuprofen. Yeah, yep.
And so you take paracetamol.
Right, yeah.
Instead.
Again, because it's the safer one.
Yeah.
That we,
And then if you had gastrointestinal complications, the perception would have been, well, it's not the paracetamol.
Yeah.
Because we took the safe one.
Oh my gosh, so imagine the medications or the treatments or the invasive diagnostic procedures that people endure because paracetamol or medications in general were ruled out as a cause of their gastric discomfort. You're not taking ibuprofen, so it couldn't have been that causing that epigastric pain you've got there, or
And it's interesting too. I noticed that there's an association with those conditions with epithelial linings and potentially for microvascular circulation. When we're talking about the kidneys and we're talking about, kidneys, hypertension, kidneys. Is it the microcirculation? Is it the epithelial linings? Is it both?
Probably both.
Because it's the COX-2 pathway that they think is being potentially inhibited, which is the issue with ibuprofen.
Right. So is it just the common enemy in the end? We thought the mechanism of action or the pathway affected was so different. These medications work so radically differently. And now that's coming into question, which I think is good. I'm seeing a line here that I haven't read before and I'm like, oh, that's okay. I want to dive into that. Okay. So he's now quoting one of the authors of the paper. Despite its perceived safety, acetaminophen is associated with several serious complications. Given its minimal analgesic effectiveness, the use of acetaminophen as the first-line oral analgesic for long-term conditions in older people requires careful reconsideration. Thank God someone said it.
Yeah.
This came up when I was first studying pharmacology at uni. A couple of lecturers were throwing paracetamol under the bus, pretty much saying they actually don't even know why it works or how it works for pain. There's studies to show that it's equivalent to placebo in analgesia. So if you hear us say analgesia, we're referring to pain relief, any substance with pain relieving qualities. But a lecturer did say that something we do know it helps with is to bring down a fever.
Yes.
Now, that's another, whether that's even indicated, whether that's even what we want to do if there's a fever at hand, is a good separate mini episode, actually.
Yeah.
But the fact that it's not even that effective at pain relief.
Yeah.
Well,
Well, they don't fully understand the mechanism of action,
Yep.
and multiple studies have shown that it's no more effective than placebo.
Yeah.
Well, that's equivalent. Well, it's not equivalent because I'm thinking of how the criticism of herbal medicines and herbal pain relief is, the worst thing that can be levelled at herbal medicine is it's only as good as placebo.
Right. Right. And now the same thing can be said for one of the most
Yeah, the most used
over the counter.
Well,
analgesic.
the most used analgesic.
Right. So what the hell are we doing?
What the hell are we?
What?
I know what we're doing. We're not questioning
Yeah.
enough.
Yeah. And look at the risk. Look at the risk associated with not questioning enough.
Yes.
Putting yourself at increased risk of things as serious as heart failure and hypertension and chronic kidney disease. When you could be doing a 30-minute guided hypnosis meditation, and that could be doing more for your pain and a range of other things.
Yeah.
Compared to popping this thing.
Yeah.
I just got that sentence just got me hyped up. Apologies.
Well, there's so many other treatments for chronic pain.
Yes.
That are over and above an oral medication.
Yeah.
So things like, for lower back pain, which is really common, there are exercises and stretching because there's an association with the fascia tightening up around an injury. So somebody might have a slipped disc, and you can have a disc dysfunction and have no pain.
Yeah.
There are many people that have had some level of an injury or something that's occurred, but they actually don't have the pain. And then there are people who do have an injury that do have pain.
Yeah.
That don't necessarily have a slip disc or anything.
Yeah.
And oftentimes it's a case of the fascia tightening up around that area, guarding the injury, and then not doing exercise, not using that part of the body, and then it becoming an area that isolates this nerve reaction, this nerve dysfunction.
Yeah. Rabbit hole. That's a rabbit hole of one example of pain. No, but to your point, I would say fascia should be looked at wherever the pain is in the body.
Absolutely.
Even if it feels like an internal pain or a headache, fascia is always going to be a key. But the bigger point there is that, one, the root cause isn't being investigated sufficiently, and looking at the body as a whole system is not being looked at. Moreover, because I'm in essay mode now. Moreover, oh shit, what was I going to say? Moreover, and look, this is maybe also a separate conversation, our relationship to pain.
Yeah.
Instead of using the pain as information to follow the breadcrumbs of clues to go, where is this coming from? What's causing it? Where is this coming from? How basic? Oh, some supportive exercises could help rebalance the imbalance that's been causing the pain.
Yeah.
Who would have thunk it?
Yeah.
But instead we see pain as bad, problem, fix it now, make it go away. Oh, if the pain is gone, I'm better.
Yeah. Yeah.
Instead of having that respect for our body and our pain signalling as my body's alerting me to something that isn't right.
Yeah.
So even if we're thinking of internal pain, if someone came to you with say some kind of abdominal pain, well, we would go through all the gut health questioning, all the immune system questioning, all the liver and kidney questioning, and we would
reproductive health questioning.
Exactly. Anything in the pelvis area, we would be looking at where's the pain coming from and how can we use a holistic, whole body system approach to actually address it.
When did it start?
Yeah.
What preceded it?
Yeah.
What's the emotional state?
Oh, absolutely. And pain and emotion, right?
Yeah.
We know with things like with chronic pain conditions like fibromyalgia as an example, like it's, I want to say undisputed. Yeah, I'm going to boldly say undisputed. Like, we know there's an emotional link there. We know there's a psychosomatic link there. Because guess what? Our nervous systems aren't just like tricking us for no reason, right? Like, they influence our whole body. You know?
Yeah.
They can trigger pain. They can signal pain.
They only have a few ways of communicating.
Yes. Yeah.
Pain is only one of the ways of communicating.
That's a great point.
It's like a baby.
Yeah.
It can only really communicate by making noises, loud noises, quiet noises, and maybe changing the tonal difference.
Yeah. And it's up to the humans around that baby to decide, are you hungry or thirsty or tired or overtired, or you need a nappy change, or there's pain, you know, like...
Yeah.
Yeah. And so that we need to be the parent of our baby bodies.
Yes.
And go, oh, what's this pain signalling to me?
Yeah.
It's not, the pain isn't signalling you need to take a Panadol.
Yeah. And also the intensity of that pain might be felt more or less differently with less sleep, with a heightened emotional state, different times of the cycle, hydration, nutrient deficiencies.
Yeah. Weather.
Yeah.
True. Yeah. We know some conditions will be worse for heat or worse for cold. Like, it's just, there are so many factors we can look at before having to put the pain away. Yeah. There's a much bigger conversation to be had around our culture's relationship with pain.
Yeah, and also there are times when we need to push through the pain in order to heal.
Yeah.
And I think this tightening of fascia is one of them. And I've just thought of an example, a knee surgery where part of the recovery post-surgery involves exercises that are painful. And it's quite common for people to not do those exercises as regularly at all, or as much, you know, taking it to the range that they need to. And they can end up with long-term pain for not having pushed through the pain for a short period of time to do those exercises, to stretch the fascia out, to get the movement in there.
Yeah. And same with, is that a similar case in, I don't know, any situation where there's a resulting scar tissue, if it's immobile for too long, you know, if there's pain and, pretty much your example on reduced movement without enough practice and stretching and mobility support, the fascia tenses up, the muscles weaken, that area of the body is less supported.
This is part of hormesis, isn't it?
Yeah, that balance.
You actually need to push to your extremities in order to maintain function. Yeah. Use it or lose it, in simple terms.
Right. And so, and I guess when it comes to pain, what's the message there? That like a healing journey is like there can and probably will be pain involved. And in fact, premenstrual Karinda is going to go as so hard as to say, like, if your healing journey is pain-free, I have questions about your healing journey. And I'm almost tempted to poke you. See how healed you are. That's just sassy premenstrual Karinda.
So back to paracetamol.
Back to paracetamol.
Not that wasn't valid. Your pain is valid.
Julie, if you're practicing getting me back on track, we'll take that as a win. We got to practice this. Okay, back to Kerry.
I was just reading there that in regard to the adverse renal effect, the researchers of this study said that, previous studies suggested that the drug can cause acute tubular necrosis with long-term use. How many people are taking paracetamol chronically, like long-term for many, many years?
Yeah. Oh, so many. Oh my God, so many. Yeah, so a decade ago, Britain's National Institute for Health and Care Excellence suggested what a phrase, suggested that the agent does, so paracetamol does, in fact, modulate the same cyclooxygenase-related pathways as non-steroidal anti-inflammatory drugs, such as ibuprofen, with the potential for adverse GI effects. And the Institute formally dropped paracetamol from its recommended treatments for osteoarthritis, both for safety and efficacy reasons. Is Australia following suit?
Oh, yeah.
Okay.
Yeah. And I think, well, I'm not sure about this specific aspect, but I know that when I was reading up for our last step, the TGA is monitoring all of this information about paracetamol and adjusting accordingly.
I hope so. Because for it to be dropped as a recommended treatment for osteoarthritis, and when I think of the typical user of Panadol, they've probably got some degree of osteoarthritis.
Yeah.
That's really significant.
Yeah. Oh. Yeah. Not just osteoarthritis, but rheumatoid arthritis as well.
Yeah. And there's so much we can do for that. There's so much we can do
for
both all kinds
addressing the root cause.
Yeah.
Because rheumatoid arthritis is an autoimmune condition.
Yeah.
But how many people have got, hypertension and taking paracetamol for I don't know, rheumatoid arthritis, one of the ands, and exacerbating this hypertension, and then having to take a hypertensive drug as well.
Yeah, maybe their dose of warfarin or whatever it is increased, and then there's more complications that come with that. And this is really the path to unwellness. When you hit that threshold in your life where it might be a diagnosis that changes it, it might be hitting a certain age or having a certain injury. This is the threshold I see so many people cross where there is going back, but it almost feels like there's no going back. And then before you know it, you're on 10 different medications,
And it's very difficult to get a medication deprescribed. I know. Because when you think about it, the practitioner that, well, obviously a GP or a specialist is going to be the person that does that, not a naturopath. Not our job. Don't take our advice when it comes to pharmaceuticals.
Yes.
But your practitioner that then decides to deprescribe something or titrate down is taking a risk then that if something reoccurs or another problem crops up, that they've taken the medication off you. So it's always safer for an allopathic practitioner to prescribe than to deprescribe.
And isn't that a bit...
Yeah.
When you think about that, yeah.
Yeah.
And you think of the amount of people who are on medications that they then realise are really complicated to come off.
Yeah.
For, reasons of, with physiological withdrawal or even just the doctor's fear being projected onto the patient, because the doctor's thinking, I don't know, what if something drastically changes if they stop this medication,
What about somebody with a complicated cardiovascular condition where they might go into hospital and they're prescribed drugs by a cardiologist that they don't see again for another 6 months or 3 months or whatever, and then they go to the GP and it's not within his scope to deprescribe, but might prescribe another medication. This is where it occurs.
It gets so complex. And I feel like I have a lot of empathy in this moment. That's a hard position for a health professional to be in. That is a lot of pressure, especially when you're dealing with cardiovascular stuff, knowing that it's one of the leading causes of mortality, and that
I'd like to say that too, that I do have a lot of sympathy for all of the allopathic practitioners, because they predominantly only have medication as a line of treatment.
Yeah.
Like maybe some lifestyle interventions.
Yeah.
But not necessarily a deep knowledge of those interventions. They don't really study nutrition, so nutrition doesn't really come into it. It's really only drug therapy, and people go in expecting to be given a prescription, a pill for a thing.
Yeah. And or they're grossly disappointed when they're like, I need to understand what's going on, and they come out of that 7-minute appointment with more confusion and like, hang on.
Yeah.
He didn't ask me enough. And that's when you come and book in with a naturopath.
That's true.
Cue the music.
The time.
You can book in to see Julie. Actually, but genuinely, was there anything more to say? Because I feel like that's 27 minutes. I feel like.
Yeah. No, I think that's a great mini ep.
That's a great mini ep. Yeah, 30. Just a quick one. Standard pod. 30 minutes is a total standard size for a podcast. So no, genuinely shout ourselves out. If you are ready and looking for an approach that goes deeper, an approach that is more holistic, an approach that factors in all the possible factors that could be contributing to your pain condition, reach out to us. You can book in for a totally obligation-free, no-cost connection call with either of us, where we just find out a little bit about what's going on for you, and we explain to you what the path of working together could look like, how we would go about your case, what sessions together would involve, what kind of treatment would be involved, and you just get to learn a little bit more about an alternative route of healing.
And if we're not, if you speak to either of us or both of us and we're not the appropriate practitioner for you, we may be able to refer on to another practitioner that does specialise in that field.
Exactly, yeah.
And, also part of that connection call is learning whether you feel comfortable working with us.
Yeah, get to know us. Yeah. See if you're not comfortable, like there's never any pressure, because that probably won't be conducive to your healing journey if we don't click.
We genuinely just want to help people.
Yeah. Yep. No coercion. Just call us if you want. So yeah. How do you reconsider?
In summary, paracetamol, not necessarily safe. Well, not safe. Not safe in the prescribed doses for short periods of time. Don't take it long term.
Find a bloody pain relieving meditation on YouTube.
Yeah, or find an exercise physiologist.
Yes.
Or go and see osteopath.
Yeah.
Shout out Bonnie Maplestone. Or a chiropractor, or a therapist.
Any other? And we say this as a reminder to you that there are so many options. Some that will require maybe a bit more investment, a bit more, and whether that's your energy investment, your time investment, your money investment.
Or just your focus.
And if the investment feels edgy, my question would be,
why?
Why? But do you want, how much better do you actually want to feel and actually be? Do you want the pain to just go away, or do you want to get to the bottom of it?
Yeah.
All right.
Thanks.
We can do this now. We can do a little physical sign off. Catch you in the next one. Thank you for listening to another episode of the Nuanced Naturopaths. Be sure to ask us any questions you have below, engage with the polls, and we'll catch you in the next one.